Okay, welcome everybody. Welcome Regina. So nice to have you with us.
Please stop me and ask me questions in between, because otherwise if you wait until the end we'll probably forget. So I'm Regina Covington. I'm an independent midwife and lactation consultant. A lactation consultant basically means that I've done some additional training to help mums with breastfeeding problems. So you can get lots of different types of breastfeeding training, but the IBCLC, which is the International Board Certified Lactation Consultant Training, is a whole year, and we go through a whole load of stuff. And I also do tongue-tie divisions. So I end up seeing lots and lots of mums who have got breastfeeding problems, and a lot of them have been told that their babies don't have tongue ties, or it's only a tiny little one and it's not going to affect any feeding. And I think, you know, from my experiences, breastfeeding shouldn't be painful. It should be nice and comfortable and easy. It might be a little bit challenging for the first few days because you're learning and your baby's learning as well. You know, you're learning to get that position right. We learn, you know, we teach you with a doll and you see videos, but when you've actually got that live human being in your hands, it's a completely different story. And the most important thing is always get some help right from the very beginning. If it doesn't feel right, then it's not right. It's not like, you know, if you buy like a new pair of shoes, you'll expect maybe the first couple of times that you wear it, it might rub a little bit, but then after that, it feels absolutely the same. Fantastic. So same for breastfeeding. First few feeds might be a little bit sore, a little bit tender, but they shouldn't last long. So any ongoing pain is not right. Any nipple compressions, the nipples can come out looking like lipstick. They can look like wedges. They might have like a little seam across them. So that's blanched white. That's all not good. That's a sign that your baby's not quite getting the breast deep enough in the mouth. So when we're breastfeeding, we're aiming to have the nipple sitting right in the top of the mouth, in the soft palate. So if you run your tongue from your teeth going backwards up there where it feels nice and soft, that's where the nipple should be. And if it sits any further forward, that's when you get compression, you get pain, and sometimes just tweaking a latch can make a big difference. But if, you know, adjusting the position, making sure your baby's really tilting the head up, chin comes in contact first, you're aiming the nipple right up towards the nose to get a nice deep latch. Sometimes just a little tug down on the chin when they're latched on, and you like, or adjust baby, move baby a little bit further away so they're reaching up, and that's all that's needed. But if it goes on, even if somebody has said that your baby hasn't got a tongue tie, certainly get somebody to have a look. As part of our training as midwives, and Nisa will agree, we're not taught to assess for tongue ties. So we don't know. You know, and quite often you'd be told, oh, it's quite normal to experience pain, when it's not. So we're not taught to assess for tongue ties. So if somebody just looks in your baby's mouth and say, nope, there is no tongue tie, then certainly get a good assessment. So tongue tie, we're looking at this part, that frenulum underneath the tongue. We've all got it, but when it causes problems with feeding, that's when we need to do something about it. And the procedure is really, really simple and straightforward. It's baby's wrapped up just to keep arms nice and still, lift up the tongue and divide the area with a scissors. And what that does is it opens up and lifts the tongue a little bit higher. So when feeding, you want baby to really get a nice big lift of the tongue to extract milk from you. So transfer milk from mum to baby nice and smoothly, and also get a nice deep latch. So when we release the frenulum, a new one will grow back further back in the mouth. Quite often I'll see mums and dads who had divisions as children, as babies, even as adults, and they have a frenulum that's further back in the mouth, just giving a bit more room and movement for that tongue so it can do what it's supposed to be doing. So we quite often sorry.
Can I just ask, how common is tongue tie? Are there any sort of stats or anything, or is it
Not
just
really. It's so in some countries they don't acknowledge that there are tongue ties. Certainly when I started as a midwife in 2000, and that's not long ago. If you think it's 20 years ago, but when you think 2000 is not a long time ago, we were always being told there's no such thing as tongue tie, and mums would be in absolute agony. Their nipples would be bleeding. There would be damage. It's toe-curlingly painful. For some babies it's not, mums and babies it's not, and for others it is. So we're getting better at diagnosing and understanding, but you will still find lots of GPs and pediatricians who'll say there's no such thing or it's overdiagnosed. I would say roughly about 10%, but then you might go into an antenatal group and every single baby in that antenatal group had a tongue tie. So is it really 10%? So yeah, it is quite common. We're seeing more and more of it than we used to. Hello, oh, a sleeping baby. Hi. So we do the division, and hopefully what that does is it opens up the area. So by dividing the frenulum in half, you go as far back as you can, and open up the area and allow the tongue to have more movement so that it can actually be a bit more efficient in the milk transfer. There is very, very little evidence surrounding speech and tongue ties, so don't let anybody scare you and say that you need to get it done, especially if there are no problems at all with feeding. Your baby's gaining weight very well, your milk supply is great, you have no pain, and those are the things that we look for, is the whole history. So not just the assessment that we have, but the whole history. So is baby feeding in a relatively decent amount of time? So if you've got very long sleepy feeds, I mean, the first few days, those of you that have babies will know that in that first week, the feeds can be quite long. You know, those first few feeds in the first 48 hours can be an hour, 2 hours, even 3 hours, and then baby wants to go back on again and again. And what they're doing is they're just saying, actually, can you make some milk? And once your milk comes in, then feeding should settle down. So a good feed can be 10 minutes long. Another good feed could be 35 minutes to 40 minutes, and baby might want one side and completely milk drunk for 3 hours, and then go on to the next feed, have the other side for 20 minutes, and half an hour later say, actually I fancy another bit, and they'll have another 20 minutes, and then half an hour later they like, actually I want a bit more, and that's a bit of cluster feeding going on. So you get that, you know, once a day, but if you've got ongoing short frequent feeds, so your baby's not once your milk has come in, your baby's not lasting for at least an hour and a half or longer between the majority of feeds, or your baby is feeding for an hour to an hour and a half before he or she finally has enough to settle down, that's a sign that the milk transfer is not great. If you've got damage to your nipples, you feel they're pinched, they're bleeding, again, that's a sign that the breast isn't as deep enough. And some babies with a tongue tie will get the breast deep enough into the mouth and not cause any problems, but they'll drink really well. And those are the kind of babies that we want to just watch when they get to about 4 months old, so about 12 to 16 weeks. They can start tailing off in their weight gain, so they don't gain as well because they've not been drinking as well. So initially, where you had loads of milk, there was no issue, but because they've not been taking out as much, your body's not been making as much, and slowly they're not getting enough to continue with their weight gain. And when we speak, if you think about it, our tongue generally tends to move forwards and backwards, but when we're eating, we use our tongue to move around the food around our mouth. So it makes a lot more movement when we're eating. And that's what we do tongue tie divisions for, is the feeding problems that you're experiencing now, or when you start weaning your baby and start introducing solids, so 6-7 months old, and you start to notice issues then, lots of gagging, food being stored up in in the soft palate, because the palate is really high up and they can't move the tongue around enough to move that food around. Those are the things. And majority of us will do tongue-tie divisions until your baby is a year old at home. After a year, then it's done in a hospital setting with anesthetic, but at home we don't use anesthetic, and it's very simple and straightforward. They might be fussy for 24, 48 hours, and majority of mums notice feeding improvement within a few days, and for some mums it can take a week or so, even a month, before you start to notice. But I think my main thing is, you know, if you've got ongoing pain, really get a good assessment. And if you're looking for a lactation consultant, I would actually find a lactation consultant that is also a tongue-tie divider, because if you're paying for it privately, you've got that additional cost of having paid that lactation consultant and the tongue-tie provider as well. And we have a website called the Association of Tongue-tie Practitioners, where all the NHS services that offer tongue-tie divisions are there, and also all the private practitioners that provide services are there as well. Some of my colleagues are doing video consults first and then coming out to see you, and some of them are offering home visits straight away. So everybody's varied, and a lot of us are in private practice, we're always available within a few days of you contacting us, unless we're on holiday. NHS can be a little bit longer waiting time, but you can equally get a cancellation within, you know, 24 hours and you've got an appointment. So I've seen many times mums have booked appointments with me and then phoned either the same day or the following day to say, actually our NHS appointments come through. So, and that's always a good sign. So.
Hooray!
Sorry, I just talk.
No, it's good. It's super interesting. I think I'm really glad that you were free to do this, Regina, because I feel like tongue-tie, because midwives aren't trained, I don't think the information always gets to mums, and unless you know someone that's had a tongue-tie kind of issue, it might be completely off your radar. You might not have, you know, have really any information about it, I think. So, you know, that's really, really fantastic. In your experience, so that I know there's so many different signs of tongue-tie, lots of different things. And my little one had a tongue-tie, and we had different small issues, but it was never one very obvious thing. And I'm a midwife, so, it took me, you know, to 3 months to kind of go, do you know what, actually we need to do something about that. So I think for your average mum it's very tricky. Yeah. When you see mums and babies, is there 1, 2 or 3 things that seem to be the most common issue with a tongue tie?
Absolutely. Painful feeding. So damage to the nipples, very long feeds, so feeds that are lasting an hour and a half. So baby goes onto the breast, has a couple of sucks, and then seems to fall asleep. And I'll get mum saying, oh, he or she's just using me as a dummy. Babies don't know what a dummy is. So the analogy I use is when you go to a restaurant, you arrive and there's some nibbles on the table, and you place your order with the serving staff, and you sit there and you eat your nibbles, and then you're sat waiting. So that's what babies do. They go on the breast, they do a little bit of sucking, and then they're waiting for the milk. So you might have a letdown and they'll suck. So you want, when a baby's feeding, what I look at is this part here, it dips down. So when they're swallowing, if the next time you have a glass of water, have a look in the mirror side on and see what this part of your chin does. It's quite a slow movement with almost a pause. And then when you just chew, like if you were chewing your food or chewing gum, it's much faster and not as deep. And so what I want to see when I'm watching a baby breastfeed is at least 1 or 2 sucks with a swallow. If I'm getting more than 3 sucks, so shallow, 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 and then deep, that tells me that this baby's working a tiny little bit faster, that it's harder than needed. And really, one of the things that you can do is just breast compression. So squeeze your boob, squeeze and hold, and then when baby starts sucking, let go. And the baby starts again, squeeze and hold. Sorry, I'm a very physical person. So
no, carry on.
Yeah, squeeze the breast, and that helps to just express some milk directly into baby. So yeah, the sleepy feeds, wanting to feed constantly, unable to put my baby down. And then we get the babies that pull back and bob on, off, on, off, on, off, really difficult to get a latch. Sometimes we'll latch on one breast, but not on the other side. But that tends to be more something to do with either the birth or the position in the uterus, because if they can latch on one side, then they'll probably latch on the other in a different position. So a rugby hold on that side, or if you're lying on your back, it more tends to be that they find it more uncomfortable to face that position, to latch on that one side. So but again, you know, you've got difficulty latching onto the breast, pain for mum, blocked ducts and mastitis. They can happen later on and can be quite recurrent, where you've constantly got mastitis again and again and again, because the breasts are just not emptying enough because of the way baby's drinking. But yeah, the biggest thing that I see is pain and either very long feeds or very short frequent feeds. So this baby that's just really unsettled and just won't be put down. That's
it sounds oh so familiar. We had a lot of that, not so much the pain, but definitely you know, it's that thing. I was like, oh, he's such a hungry baby.
Yes,
it must be because he's a boy.
Or he's a big baby. Oh, he's a big baby. He's hungry. But you know, irrespective of whether you have a 7-pound baby or a 10-pound baby, their tummies are exactly the same size when they're born. So you know, this one's not hungrier than that one. It's just that nothing's going in. And you know, when babies are born, their tummies are so tiny, they've hardly ever expanded. I mean, they've drunk amniotic fluid, and there's skin cells and hair follicles and nails and stuff like that in their stomach, and that's what comes out as the thick tarry black meconium. But once you start feeding, their tummies are sort of like about a teaspoon in size for the first day or so. So tiny, you know, like a little grape. Yeah, 5 mils per feed. So baby could be on the breast for, you know, 30 minutes, then 30 minutes, and then another 30 and 30 after birth, and then okay, I've gone off to sleep. All they're doing is just stimulating and just, you know, getting that colostrum flowing so that your breast can start producing milk. And after this, the second to third day, depends on how feeding's going, that volume increases to about 20 to 30 mils per feeding. As long as feeding is going well, the volume just increases very gradually. And there's a reason for that. Babies have never digested milk before. And if you think of all the components inside milk, all the stuff that we're eating every single meal is completely different. All of that is transferring into our milk. So our babies' bodies are learning to digest all of those. They just need to do it in small little quantities at a time. So day 2, day 3, you're looking at about 20 to 30 mils per feed. By the time your baby's 5 to 7 days old, your milk will have definitely come in, and then you could get sort of like between 50 to 70 mils per feeding each time, and then it just slowly increases. And babies take what they want. When they've had enough, you can't force them. Mouth is closed, won't open wide enough. If they're hungry, you get that great big mouth that looks like a yawn saying, I want to go on.
That's perfect. Love. Do excuse the noisy toys in the background. And tell me another thing. So is there a more common time that mums will come to you, or, you know, in terms of the issues, will be there from the start for most women, or would it appear, you know, later as well?
Yeah, I'd probably say about 75% of mums have had problems right from the very beginning and have been fobbed off and said there's nothing. So just to show you, so if somebody saw a baby like this one here, let's have a quick look. So is that visible at all or not? Can you see the frenulum right here and the tip of baby's tongue? Yeah, so that little bit underneath here is coming right to the tip of the tongue. People will be like, yep, can see a tongue tie, but that baby could actually latch on without causing mum any problems and feed really beautifully. And then the one that you can barely see anything, so they cry, they lift their tongue up, it's not heart shaped, it's nice and rounded. some of those babies can be the ones that get missed. So there's those ongoing problems where babies had difficulty latching, mums had painful feeds, and everybody said, no, just push through it, there's no tongue tie. Those are the ones that tend to get missed. When you finally do that division for that baby, mum's like, oh, this is what breastfeeding should be like. So. And then the ones that tend to come to me, some of the ones that come to me much later on are the babies that have been doing really well initially, but when they get to sort of 3-4 months old, are suffering from really bad reflux, wind, very unsettled, unhappy babies, lots of spitting up or maybe not spitting up, just crying, you can't put that baby down, maybe weight gain isn't that great. Those are the ones that initially were doing really, really well, and everybody was like, no problem at all. But again, some babies with tongue ties never have a problem. You know, they'll feed really well and you know, not experience any digestive discomforts. They'll just go on and be really happy thrivers.
I think that's a top point, Regina. The that you can actually, you know, be doing fine with the breastfeeding, and then obviously not the majority, but for some babies it's that windiness. They're getting lots of air down as they feed because of the latch isn't so great. So it might not be that you've got, you know, terrible pain in the breast, they might be gaining weight, but that might be another sign that they've got loads of gas and they don't settle. Hello.
And I often hear from mums that they can hear air going in, so you can hear the milk hitting the stomach. So if you imagine when you've got an empty stomach and you get a big bottle of water and you start chugging it down, you can hear it going down into your stomach. For some babies, we can hear that when they're feeding, and that's air going in because of the latch, because they've not got a great seal because of the tongue tie. And that might be okay for a little while, and then eventually that accumulation of gas in the stomach just starts to cause them lots and lots of problems.
Poor little ones. Something that you told me, so when you came to see us, must have been about, gosh, 6 weeks or a couple of months ago, I described all the things that we had, all these little funny things that were happening. And one of the things that I said was that he never slept on his back. Didn't like to sleep on his back, didn't really like to be put down on his back when he was little, at least for, gosh, even up to 3 months. Didn't really like the car seat either. And you maybe tell everybody a little bit what, you know, it's something that you'd noticed. It's, as a practitioner, it's a kind of, seems like a pattern.
Yeah, and again, this is some babies and not all babies, where just that position being back, it could be the way the tongue is sitting in the mouth. They just, it's really, really uncomfortable for them. They really just don't like it at all. And again, if your baby has started to develop reflux, so with reflux, initially it's like heartburn, nothing's coming up, but you can feel that sensation, and all they want to do is go back onto the breast and just have another little sip because it soothes the esophagus. And then 10 minutes later they're back on, and it's a really short feed. It's just snacking constantly because it soothes this. But you put them down flat, they don't like it because the acid is coming back up, and if that acid continues coming back up, then they start becoming really irritable and miserable babies. And you're like, but and these are the babies that gain weight really, really well because they're constantly going back on again and again and again, and everybody's, well, he's gaining weight really well, but it's because he's just constantly snacking because he's really irritated. And occasionally you might get a good-ish feed, slightly longer, but most of the time it's just to soothe this area that feels really horrible. So yeah,
and I think that would be so easy to miss.
Mm-hmm.
You know, it's not the classic, so you might not even think tongue tie. So I think that's super useful. Thank you. That was amazing. Ladies, I just wanted to say, you know, anyone that would like to ask anything about tongue ties, but also breastfeeding, because Regina's a lactation consultant and a midwife and many, many, many things. So either you're welcome to ask anything to do with that, or for the postnatal. I'm going to mute myself because we're very noisy. Please feel free. Hi, Regina.
Hey.
Thanks so much for that introduction. It's really helpful, and I'm recognising a lot of what you've said.
Right.
Had a really difficult last few days actually with the breastfeeding. I've been discharged from the midwife now because the baby's gained weight. She is feeding, and she's gained weight. They always ask, is she gaining weight and what are her nappies like?
Yeah.
And she's ticked both boxes, but it's the issue with me at the moment. So I'm in terrible pain when she's trying to latch on. And I've now developed mastitis. I've literally just picked up some antibiotics today, this morning. And it's the last couple of days it's been excruciating with her trying to latch. And I've kind of been led to believe that it's the issues with latching, and that it might not be tongue tie. But yeah, it's just, I don't really know what my next steps might be to try and get it resolved.
And have you seen somebody to help you with breastfeeding?
I did some breastfeeding with my midwife. She wanted to see how she latched on because we suspected it might be tongue tie, but she didn't seem to have anything to say about the position.
So the bottom lip is nicely curled down and the top lip is nice and neutral.
So she has a really shallow latch, and I sometimes try and pull this bit down. I've tried squeezing so that it's more like a sandwich.
Yeah.
I've tried, so I've looked at all sorts of different things, and I find that it's really painful at the beginning and at the end, but sometimes once she's on and she's sucking, it's comfortable. So she will feed, and she is clearly getting milk.
So a couple of things that you can get that I forgot to mention earlier on is the excessive weight loss in those first 5 days. So by the time you get to day 5, your baby's lost 10% or even more. And again, if you've had an epidural for quite a long time, or you've had lots of you've just sort of like had a fluid overload in you, I would probably expect your baby to lose a little bit more weight than suspected. Reduced nappies as well, so not getting enough wheeze and poos initially, that can be a sign. So the other things that can cause some latch issues is the birth itself. So very long second stage, if you've been pushing for a very long time, your baby maybe wasn't sort of like tucked in really nicely. Maybe your baby comes out and you notice there's sort of like a little lump here. That's where they were sort of like leading out from. So they're not quite getting when they go onto the breast. It's sort of like a smaller mouth. And you can get babies that will get a nice wide mouth, but it just doesn't feel great to keep it open, and they slip down and to the nipple. So that would be that pain that you're getting in the end. Forceps and ventouses can do that. So if you imagine they're pulling along here or sucking along here, that can cause lots of compressions and tensions. One of the things that I always recommend to mums as a first option is actually just getting your baby seen by a cranial osteopath and just see if there's any pulls and tightening and compression that could be preventing a good latch from happening. And then obviously if there's nothing in the birth and nothing, you know, anatomically, structurally with babies, then we kind of, not anatomically, but sort of like in the birth, so then we're looking at, you know, is there a tongue tie? And the way we do an assessment, so we use 7 points for function and 5 points for appearance. So the appearance we're looking at is where is the attachment to the tongue and the bottom of the mouth, how it feels. Does it feel thick or thin? Does it feel like a speed bump? So you pop your finger underneath and it feels like a bump, or is it very, very clearly visible, like a piece of cling film underneath there? When your baby cries, what does that tongue look like? Does it stay quite low in the mouth, or does it have a nice big lift up? So we want a really good lift. Or is it just lifting just on the tip here? So you just got like a little basin coming. How much your baby sticks the tongue out? Does the tongue come nice and forward out, or is it just barely lip licking? And clicking as well, so that clicking going on during a feed, that can be another sign. So it may be worth getting either see if you can get baby seen by cranial osteopath, or have a look on the Association of Tongue Tie Practitioners and have an appointment with, I would always go for somebody that has got IBCLC next to their name as well, because it means that they're a lactation consultant, so they're not going to just come in and just do a division, because I do know some of my colleagues don't provide any additional support. It's just tongue tie assessment and division, but their breastfeeding knowledge and skill isn't that great, so they can't give you as much. And then maybe perhaps trying a different feeding position, so sort of like a seated baby in front of you, so a koala, and see if you can get a latch that way, a nice deep latch.
Thank you, I'll try that.
Hi, can I ask a question?
Sure.
I just wonder if you've got any advice for those people that might fall into the 3-month category. Because basically I've got a very windy baby who has got a tongue tie, and I've been back and forth a little bit with the health visitor, and I actually went for an appointment to have the tongue tie cut, only to arrive at the appointment and the particular person who was assessing it thought it wasn't appropriate because I don't have any pain feeding. She's very nice and chubby and not the classic symptoms, so they didn't think it was appropriate to cut it. So they sort of left the decision up to me, and I didn't know what to do, so I didn't cut it in the end. But similar things to what you've been saying about not wanting to lie down and very unsettled, probably taking down quite a lot of air, I think, when feeding. So
And has your baby been seen by an osteopath?
yes, yeah, they did, because it was a forceps delivery. So they have said that there was some woodenness, as they called it, in the left side.
So maybe a bit of stiffness on that side, maybe some pulling. Of woodenness.
So she has had a couple of manipulations of the osteopath, but I didn't particularly think it's made a lot of difference so far. Gripe water's the only thing that's worked a little bit so far, but she's still pretty bad at sleeping on her back. But I don't know if it's normal baby sleeping issues or not. It's difficult. It's a difficult decision whether to cut it or wait and see, or
yeah, it certainly is. And you know, when I go and see mums, I always give them that option, even if it's very obvious there is a tongue tie and baby would benefit from it. I don't want to influence a mum in either making the decision to do a division or not making it. It has to be your decision. And some mums will say, actually, do you know what, we're not doing too badly, so we're just going to wait and see. And other mums will be like, no, I've been here before with my other baby, or I just can't do this, I dread every single feed, and just go ahead and do it. And I'll equally see mums that have got, they're in agony, you can see their nipples are bleeding, and they'll be like, actually I'm not sure if I want to do it or not, you know. So
I think when the feeding is not painful for me, I'm not having a problem, then it's really just seeing her in distress when she's so unsettled in between feeds and really crying a lot and not wanting to sleep and getting really tired, then it's whether it's best for her. But it's just confusing, to be honest, with the different
and only you can make that decision whether to go ahead and have that division done or not. How much tummy time does she have? Because I find that tummy time makes a great big difference in baby.
Oh dear, to be honest, not much, because she doesn't like tummy time much when we've tried it. So
they don't, and you have to sort of like start with 2 or 3 minutes at a time. And you can, so that my babies that I'm a midwife for, I'll start it from day 0. As soon as they're born, a couple of minutes on their tummy every single day, morning and afternoon, and slowly build it up. And they really do it, and it makes a big difference, because lots of babies like pressure on their tummy, so holding them really high up on your shoulder, that makes a difference, or having them on your laps, on your lap, sort of like facing down, that can make a difference for a lot of babies. So just find like tummy time makes a huge difference, and really always starting with a couple of minutes at a time, and see how that progresses.
Okay.
A lot of these, if you find a lot of these problems that babies experience with digestive discomfort, when babies start crawling around, they all disappear completely because they're spending a lot of time on their bellies.
Oh, right. Okay. Lovely. Thank you very much.
Do you think your NHS appointment is still open?
Yeah, I think I can rebook another appointment if I want to.
If you felt that things, and again, it can be really difficult in, as a mum, putting your baby through something like this. It is a painful procedure. Babies do cry, but they literally cry for 30 seconds, a minute or so. They not much longer than that. And for mums, just, you have an emotional attachment to your little one, and it can be quite difficult to make that decision, especially if you have no pain and you're like, do I really want to do this to my baba? So yeah, it's very hard. Even when your baba is a grown-up person, you still might find it very hard to make such decisions.
But generally, you think it sounds like it could help in my situation? Yeah. Okay, that's good to know.
And the thing is, you're looking at the situation and thinking, how bad is this? Does something have to give, or are we managing? Are we okay? And it's just sort of like very little niggly things that are going on.
Yeah. Okay. Lovely.
I can completely relate to that. So ours wasn't so obvious. It wasn't, terrible. It was just, a little bit now, a little bit then, and then it didn't correct over the weeks, and then it would come and go. And the amount of times I kind of thought, oh, should I see someone? And then in the end, I did. And I must say, from my experience, I'm so grateful that we saw you, Regina, because actually within a week for us, not that it's like this for everyone, but for us, the discomfort had gone, slight discomfort in the boobs had gone. He was much less windy. He was feeding, the feeds just shrunk in length. It was like, oh my goodness, that was really amazing. It went from probably 45 minutes, an hour sometimes, to about 15, 20 minutes. So it afterwards, I could see it was so obvious, but at the time I ummed and ahed for weeks. It's not always easy. It's a tricky one for sure. How about any oh, go on, lovely.
No, I was just going to say, and sometimes it just doesn't work for some mums and babies who do tongue-tied divisions, and there is absolutely no change, no improvement at all. Sometimes it can take a whole month, 6 weeks before you notice it. There is a forum on Facebook for support for mums, for parents with babies that have got tongue ties, and I will sometimes point mums who are undecided to that forum, so just so that they can see what other people are posting, and to help them make a decision whether to go ahead or not go ahead. So, but it's always, I think it's really important to have realistic expectations. And again, from a practitioner's point of view, I tend to find that the more restrictive the tongue is, the frenulum is in letting the tongue move around, the better success rates mums will have, and the more freedom that tongue has. Just when you've got those niggly, like Mrs. and
Indy.
Those are the classic woman baby that I might see, and they might not get any results because it's just little niggly bits and not one specific bit. So
that's really useful. That's super useful. Any other questions, ladies? Anybody like to ask anything else? We've got Regina for another 10 minutes. I know she's a very busy woman, but please feel free. Go on, lovely.
I have a question regarding the baby's discomfort with the procedure.
Yeah.
And how long, because if it happened to me,
yeah,
I would have a problem with the baby suffering from the snap without without the anesthesia or something. And also I would think for a few hours or days, she might then have an issue with feeding because it would hurt
Yeah, so absolutely, so all very valid things. So certainly that can happen, that in the first 24, 48 hours, sometimes babies just won't feed at all, very rarely, but they can become quite fussy. After 8 weeks, we can give them Calpol, unless they were premature babies. So if your baby's older than 8 weeks, when you do the tongue-tie division, you can have Calpol handy. Majority of babies don't actually need anything. They just might need, you just find that their feeding changes a little bit for 24 hours. It's like when they have their immunizations, they're quite miserable for a day or two. They cry a lot, they don't want to be put down, they'll just snack on the breast, go on, have a little bit of a sip, and then they've had enough, but they don't, you've just got to pop them in a sling. So they do cry when we do the division, and the crying is, for most babies, is over and done with within a minute, because they latch onto the breast and they start feeding. Some babies will cry for a little bit longer. I liken it, and again, we're never going to know what it feels like, unfortunately, but I liken it to when you bite your tongue or your cheek. It hurts when you initially do it, and then it calms down for a few hours, and then the area swells up, and every time you eat or you speak, it's uncomfortable. But when you're just sat there without your tongue moving around, you don't notice it, and then about 24 hours later, it's completely disappeared. So the mouth itself heals really, really quickly. What we do get underneath the tongue is what looks like a mouth ulcer for anywhere from about a week to up to about 3 weeks. But that in itself doesn't heal, it doesn't cause any pain at all. It's just that initial discomfort and possibly the first 24, 48 hours. So I'd always say just make sure that you don't have plans to be out and about and doing stuff in case you have a baby that's unsettled. Some babies are absolutely fine, no problems at all, and other babies just like, actually something hurts and I don't know what it is, so Boo-Boo's going to fix it. Boo-Boo's always the answer, 99.9% of the time. Whatever it is, it's the answer. So.
Thank you.
Can I just ask on that same point as well? I'd heard from a friend that had a tongue tie cut that they were recommended to stick their finger and manipulate in the mouth, which they found very traumatic because they were told it might just grow back the same otherwise. And I think that was very distressing for the baby. I don't know if that's something that everybody gets told when they have a tongue tie cut, or
no,
because it sounds horrendous.
It certainly is, and it's a very American-based approach. It's not evidence-based. So there are two hospitals. One is King's College and the other is Evelina Children's Hospital, and they advocate wound disruption. So basically you're keeping the wound open. The risk of reattachment when you do a tongue-tie division is 5% because the body wants to go back together as it was, and what we want to do is try and prevent that from healing together because you're back to square one. So you'll find that those of us that are listed on the Association of Tongue-Tie Practitioners website, we ask you to do a tug of war. So let baby suck on your finger and just play this little tug of war game with your baby for about a minute every time that you're going to feed. And then you brush the bottom gum like you're brushing teeth from left side to right side so your baby can follow one direction and the other. And for somebody like yourself who's got, baby's 7 weeks old now, get that going. Stick that tongue out, and the younger babies will do it as well. It takes a lot more before they start copying you, but the older they are, the easier. They're more interested in what's going on in your face, so they will copy. So we just want that tongue movement as much as possible. And then the American-based approach really is lift up the tongue, so 2 fingers on the chin, thumbs on the chin, 2 fingers under the tongue, and stretch it to open it. So you're just lifting the tongue to keep the wound open, and then you rub your finger across under the tongue where the cut is, from side to side, and they recommend between 4 and 6 times a day to do that. They still do reattach, unfortunately, irrespective of what you do, and some people don't even mention any exercises at all, and those babies don't reattach, or they might reattach. So we just don't know who's going to get a reattachment or not. And you'll find again on forums people who are saying like, we're going for our 4th division because it's reattached yet again. So
wow, those tongues really just want to be down.
Absolutely.
Oh.
Regina, just
a really quick one. You mentioned, Anissa, the long feeds and that being one of the signs.
Mhm.
Is there anything in shorter feeds? Because I find with Lily, my little one, she doesn't have long feeds at all. She has lots of shorter feeds, usually lasting between 10 and 15 minutes, often just from one side. She then falls asleep and isn't interested in going back on to either side. And I wondered whether she might be tiring herself out quite quickly because she's working hard.
How long would she go from one feed to the next?
She's 3 weeks old. The last week, I'd say she at most will go 2 hours.
Okay.
But the last couple of days, I feel like she's been cluster feeding quite a bit. So she yeah.
Yeah, you can get growth spurt around about now, 2 to 3
Yeah.
weeks. Every 2 to 3 weeks, you've got a growth spurt. What you can do is to breast compressions when she's feeding. If you feel like actually maybe she's not taking enough, go with the breast compressions. So with short feeds, what we don't want to see is that cluster feeding 24/7 every single day.
Mm-hmm.
That says that baby's not quite getting enough. So she's just like, okay, I'm really exhausted, I'm going to have a break. But if you're getting anywhere from regularly an hour and a half to 2 hours in between feeds, majority of the time, that's perfectly normal. And all babies do one cluster feed session per day. And it's exhausting because that will kind of be from about 8, 9 o'clock until 1 or 2 o'clock in the morning, or some of them will do it at 2 o'clock in the morning. They just want to go back on again and again and again. So cluster feeding is exhausting, but every baby does it. And as long as it's not something that's going on 24 hours a day, every single day. So you'll get a day or two where your baby's going through a growth spurt and you'll get that cluster feeding going on. But the rest of the time, a short feed with a good settled period in between is a good sign. It just shows efficiency.
Good.
Oh, good news. Good news. Ladies, that's nearly time. I'm sure we could probably carry on forever, but we have to let Regina go. But let me ask you, Regina, so when I post this on the internet, where's the best place to find you? Give us your website and I'll add it in when I post.
Oh, okay, you can do, yeah. So it's rightsofpassagemidwifery.com.
Perfect. Rightsofpassagemidwifery.com. And where do you see ladies?
Yeah, all visits are in Mum's home, and I'm in Enfield in North London. So I do probably about maximum an hour's drive from where I am. It depends. I mean, if you're south of the river, you probably don't stand a chance with me. I'd refer you to one of my colleagues. It's just such a pain to get across there. It's not that far mileage wise. It might be sort of like 12-15 miles, but could take over an hour to get through the Blackwall Tunnel or Rotherhithe. So I just don't do that journey at all. And then again, I might do sort of like the lower borders of Essex. I try not to go too far into Essex because it's a huge county, and one journey, yes, it can be sort of like a 45-minute drive, but you've done like 50-60 miles to get to somebody. So yeah, I would
fair enough
put somebody on to that. So yeah, sort of like the lower parts of Hertfordshire, Essex, and London, northwest, east. North and east are my favourite, but yeah, I go to West London as well.
I'm very glad that I live in East London and we got to see you. That's perfect. Thank you for your time, love. Really, really appreciate you joining us today. And ladies, I'll be back next week, every Monday at 12. Would love to see you. You're all always welcome. Same link as ever. And yeah, that's it. Have a wonderful week, everybody.
Lovely to meet you.
Thanks so much.
Bye now. Bye-bye.
Bye, everyone.
Thank you. Bye-bye.
Bye. Thank you.